Hello and good evening, everyone. Welcome to the inaugural day of the MeHeLP Dissemination Conference Kerala segment. Let's begin the conference with the inaugural address. To give the inaugural address today, we have Dr. Mohanan Kunnummel with us. Dr. Mohanan was a professor at the Department of Radiodiagnosis at Thrissur Medical College for a long time. In 2016, he was appointed as the principal of Manjeri Government Medical College. After retirement, he has been working as the head of the Department of Radiodiagnosis in Perindalmanna MES Medical College. He has bagged many honors, including the state government's award for the best doctor in 2016. Dr. Mohanan is the Vice-Chancellor of Kerala University of Health Sciences, Thrissur, and the President of Association of Indian Health Sciences Universities. Along with Dr. Mohanan, I would like to welcome MeHeLP Principal Investigator Dr. Raghu Raghavan and Co-Investigator Professor Asha Banu Soletti. It's my pleasure to welcome you, Dr. Mohanan, to the MeHeLP India Dissemination Conference 2021.
Namaste, good afternoon, good evening, or good morning, wherever you are. It's a very pleasure to welcome you all to this first virtual conference of MeHeLP India, Mental Health Literacy Project in India, in rural and urban India, and this actually happens to be in Kerala. It is my great pleasure and privilege to stand before you for this inaugural session for this mental health literacy project in urban and rural and tribal Kerala using applied theatre and other creative methods. This is a UK Research Council funded project which actually started in September 2018, and we are actually coming to the 3 years or 3.5 years to the end of this project. So this is the dissemination conference where we are hoping to actually discuss all the findings and all the processes as how we have actually got to today in 2021 October in relation to where we are with the project. And mental health literacy is a need of the hour throughout the world. The world has actually changed over the last 2 years because of the COVID pandemic. Obviously, and hence we were actually hoping to actually have a face-to-face conference towards the end of 2021 in Kerala, but however that is not possible, and hence we have actually organized a virtual conference where we have much more of an interactive experience to discuss, to debate, and also to inform about culturally appropriate mental health literacy and how we actually promote that in Kerala and also in the rest of India. It has been a challenge for us. It has been a great challenge for us over the last 3 years is how we operationalize the project in the midst of the COVID pandemic. But somehow we have actually come to the end of it in one piece because of the teamwork of the India team and also our consultants and everybody else who actually partake in this venture in promoting our ambition, our aim in terms of how we can promote mental health literacy in India. So I wish to thank all the organizers who made this possible to have this virtual conference today. We have 6 days of debates and discussions, the 3 of the Kerala dates, today, tomorrow, and the day after tomorrow, and also the next week in terms of the Pan-India conference, where we actually have eminent Indian speakers and organizers and NGOs coming together to discuss mental health literacy. So it is a warm welcome to all of you from the UK. I'm staying in the UK. I'm talking to different people around the world. So it is a great pleasure to actually stand before you and welcome you all as a lead for the mental health literacy project here. So do interact with us and also be and part of us in terms of promoting the project for us, not just for the end of this year and also for the next 10 or 15 years into making it a reality in Kerala and also in India. Now it is my great pleasure to welcome Professor Mohanan Kunnummel, Vice-Chancellor of the Kerala University of Health Sciences, to inaugurate our first 3 days of the conference, that is with a Kerala focus. Welcome to you, sir.
Good evening from Kerala. Of course, it must be good morning or good afternoon in other parts of the world. Uh, Professor Raghu Raghavan, Principal Investigator of the MeHeLP program, Professor Asha Banu Soletti, Professor of Tata Institute of Social Sciences, Mumbai, esteemed faculty members and participants of the three-day MeHeLP Kerala conference. Let me at the outset thank the organizers for giving me an opportunity to be a part of this virtual meet. I'm extremely happy to participate in this conference as it addresses a very important concern of Kerala state, the mental health literacy among the people. Also, the conference is relevant now as we are in the midst of the COVID-19 pandemic. Even though the WHO definition of health includes physical and mental health and also social well being, for most people, health means physical or mere health only. Mental health needs same or more attention as physical health. And this is possible only by improving mental health literacy among all. And I believe that is the message of this conference. In this context, what MeHeLP is doing is a great service. I'm sure that your study will give us a clarity on the level of literacy or correct awareness among general population regarding mental health. We are in the midst of the COVID-19 pandemic. Whole world is concerned about the physical problems produced by the COVID-19. But the mental problems produced by COVID-19 also needs equal attention. I'm happy to note that mental health professionals in Kerala state are giving excellent support to those who are in need. But the number of health professionals in the state are not sufficient enough to meet a pandemic situation. And therefore, basic MBBS doctors, Ayurveda, homeo graduates, nurses, and all allied health professionals also must be enabled to identify mental health problems and offer support as well as proper referral. Using theater, films, and storytelling for improving mental health literacy is a very bold initiative. A Marathi movie Astu, created by the eminent psychiatrist Dr. Mohanan, could create awareness about Alzheimer's disease and dementia better than 100 classes or 1,000 books. That is the power of art. Most of the mental health problems have excellently been uh, cured and the remedies are available in modern science. Research on brain function is producing exact answers to many mental conditions. As a radiologist, I am aware that great advances are reported in the field of brain imaging in mental health abnormalities. By functional MRI, molecular imaging, and PET imaging, we may be able to diagnose mental diseases which have a biological basis. However, even today, at least some people are dependent on astrologers, mandravadis, ustas, and many other pseudo therapists for treating mental conditions. This is happening even in a literate state like Kerala. Maybe because of the increased literacy, instead of old mandravadis, we have WhatsApp gurus and social media fake doctors. Very often it is difficult to know which is science and pseudoscience. The problem can be solved by correct dissemination of accurate scientific knowledge, and that MeHeLP will be able to do. That's what I am hoping. Recently, our university conducted a study on changes in family structure in Kerala. As expected, it underlined the fact that most families are nuclear now, no big joint families. Also, divorce rate is increasing because of the increased longevity of life especially among females, and since many of them are living alone, their mental problems are increasing. Kerala University of Health Sciences is committed to find solutions to all these problems. We are happy to collaborate with MeHeLP in order to solve the mental health problems facing our citizens. With these few words, I declare the 3-day MeHeLP Kerala conference inaugurated. Thank you once again for inviting me. Thank you all. Namaste.
Thank you very much, Professor Mohanan Kunnummel. Thank you very much for those words, enlightening words in relation to the relevance of mental health literacy in Kerala and also in the rest of India. And I think the opportunities that actually poses for us, academics, researchers from different walks of life to come together and to try and address this using creative methods, using different ways of actually thinking about it. And I think it's important that the psychological world, the psychiatric world, and everybody need to actually work together to creative arts, to create that, to develop that knowledge and awareness, and also to develop practices in the state as well. And we'll be more than happy to collaborate with you in relation to the future ventures that we have planned in relation to. Many thanks for your time. Many thanks for coming on board for us and also blessing our occasion in relation to this great event where we are fearlessly talking about mental health and well-being. And I think it is not done very frequently. And I think this is a very challenging concept in relation to how we actually talk about it in the first instance, and also how we try and address the issues that surrounds each and every one of us in our own families and our own employers and our own societies. And I think it is important that we should be addressing this head on in relation to where we want to go in the future. Thank you very much indeed, Professor.
Thank you, Dr. Mohanan Kunnummel, for your kind words. Let us now move on to the sessions for the day. The topic for the first session is Culturally Appropriate Mental Health Literacy. This session will be chaired by Dr. Shaji KS. Dr. Shaji was trained in psychiatry at Christian Medical College, Vellore. He joined the faculty at CMC Vellore and then at Government College, Thrissur. He was the professor and head of the Department of Psychiatry, Government Medical College, Thrissur till 2020. He is currently the Dean Research at the Kerala University of Health Sciences, Thrissur. Welcome, Dr. Shaji, and over to you now.
Thank you very much. I hope we will start the timer now, and then we have a very interesting session ahead of us. This is Culturally Appropriate Mental Health Literacy. That is the opening session. It's of about 15 minutes duration, and we have 4+2, that's 6 speakers. 3 will speak for 10 minutes each, and then last 3 will speak again for 10 minutes. So we are hoping to have very brief presentations, and then hopefully through the chat box we will find out the queries and then try to answer them. So it's my pleasure to introduce 6 of them, in fact, quickly. They are Professor Asha Banu Soletti, who is the principal investigator here, will be speaking on mental health care for all in Kerala. I'll briefly introduce her later. Then, of course, Professor Raghu Raghavan. Then Nadia will be speaking, and then Ananda Wilson, and then Sanjana Kumar and Aarcha. So these are the 6 people. The first session will be handled by Dr. Asha Soletti. She is from Tata Institute, the very well-known institute in the country, doing extremely good work. She is the Dean of Student Affairs there. And then, of course, for the sake of brevity of time, I will cut short reading her biodata. She presently coordinates a field action project called Integrated Health and Development Project, which is basically for the tribal belt. and then actively involves in training and capacity building at this. I'm sure she will talk greatly on her allotted topic. Then Professor Raghu Raghavan, who is an expert in transcultural mental health and well-being, will follow. He will be talking about his research and related issues. He works at the University, De Montfort University, along with Dr. Nadia, who will again be the third speaker. She's again from De Montfort University. She completed her PhD with focus on social and developmental psychology and works at the University of Leicester. Her primary interests are among, she's working with children and adolescents and in the field of mental health, of course. Then you have Amanda Wilson, and then she works as a qualitative psychologist who uses discourse analysis to understand marginalization and health. So again, she is in the field of mental health, reproductive health, sexual health. She, along with Sanjana Kumar, I hope she is somewhere connected to a village called Chandamangalam. I do not know. I'll find out from her. I come from that village. Aarcha Gowri Varma, of course. She again is an MPhil in social work from Institute of Mental Health and Neurosciences at Calicut. So we are hoping to quickly have this session. 4 sessions in total, 10 minutes each. Your slides are there. You might start now.
Okay, thank you very much, Dr. Shaji. In this session, I'm going to actually briefly talk about the project aims and objectives and how well we are in relation to promoting mental health literacy in Kerala. So first of all, I must actually thank all these people who actually made this possible over the last 3 years, a number of academics and researchers who have actually worked with us, currently working with us, and also worked with us in the past, who have been involved in data collection and a number of other procedures as well. So thank you very much, team. You've done a wonderful job. And also to our India project partners and also the UK project partners, both from arts and mental health, and also from digital technology and IT as well. Thank you very much indeed. So the Kerala, why this project? Why mental health literacy? About the National Survey of India, National Mental Health Survey of India in 2017 talks about 13.7% of the national prevalence of mental health disorders in India. And obviously there is the Kerala success model within it, internationally well known, with the population about 36 million, human development index of 0.79, highest in the state of India, and highest literacy rate in India as well, with 98%, and life expectancy of 74 years, and one of the lowest fertility rates in India as well. And healthcare and general high development indicators are actually recorded in Kerala. And Kerala indeed actually represents the direction in which many other regions in India desire to travel in terms of education, healthcare, and social mobilities. But the challenges of the Kerala model also have some negativities in terms of 14.4% of the adult population experience mental ill health once in their lifetime, and about 12.5% of the individuals with suicidal risk, which is double the national average of India. And most of the reports also suggest that depression is the lead cause in Kerala. The fast economic social transformations, decline of the joint family system, high standards of education versus low employment, high migration, and high expectations versus harsh economic realities, heavy alcohol consumption, and school pressure on children as well. And on top of that, and I think we have the COVID pandemic mental health issues that is actually related to it over the last 2 years. So within the existing solutions in Kerala, states about the community-based mental health models. There are also psychiatric pluralism is also prevalent there. The biomedic, Ayurvedic, and religious healing practices exist. But there is the persistent challenge of stigma, the stigma around mental health. Consequently, there is the internalization of the public perceptions. They are resistant to approach mental health facilities and mental illness as reflecting poorly on the family lineage in terms of affecting marriage, etc. So within that context, the mental health interventions need to be more responsive to the local, cultural, economic, and social context that are accessible and affordable to the communities. So hence, our project actually used a novel applied theatre, storytelling, short film methodology to explore and develop culturally appropriate and acceptable mental health narratives in Kerala in rural and urban and tribal communities. So we are an international interdisciplinary collaborative partnership between India scholars and the UK scholars and theatre practitioners and filmmakers. So we're using a novel methodology. How can we tell the story? How can we tell the story that is more understandable by people? How can we mobilize the communities? How can we enable the people to be engaged in that conversation, in that fearless conversation around mental health and well-being? So we want to build that capacity for future research and also develop the practices in Kerala and the rest of India as well for international significance in social sciences and health humanities with reference to mental health literacy, mental health recovery, and well-being. In terms of the mental health literacy angle, in a good mental health is not mental illness. Good mental health is an integral part of a person's well-being and development. It actually embedded in all our aspects of life in terms of beliefs, the faith, the culture, environment, spirituality, work, housing, education, family, community respect, and a number of other things as well. So within that, culture is actually very important. Culture shapes the way we think, whatever it is. Culture shapes the way we think. So his understanding of mental health and mental illness within that cultural context is essential, and the types of and the types of help that people actually seek and the coping styles and the social supports are also important here. And availability and acceptability of mental health services is also very crucial in this context. And actually, they actually differ from the low middle income countries and the high income countries as well. So we need to be enhancing the community by mental health literacy and how people perceive the help-seeking behavior and enable them to actually approach professionals and also to understand the whole concept of mental health and well-being. So what is mental health literacy? Mental health literacy is actually a Western concept. And here we are actually talking about mental health literacy, the ability to recognize specific conditions or disorders or different types of psychological distress. We're also thinking about the knowledge about risk factors and causes, and the knowledge about self-help interventions, and knowledge about professional help available here, attitudes which actually facilitate the recognition, i.e. the stigma element that actually affects the help-seeking behaviors, and knowledge about how to seek mental health information. And to that, I think we wish to add the concept of cultural awareness and cultural knowledge and cultural know-how as to how some of those things actually facilitates or influence the way we see mental health and well-being and also help seeking for mental illness. And obviously, indeed, the National Mental Health Survey of India 2017 highlights the need for mental health promotion. It talks about mental health promotion, early recognition, care support, and rights of the mentally ill, and destigmatization. It is actually within this context that our research looks at a feasibility study of how to promote the socially and culturally appropriate mental health literacy using participatory approaches. So throughout our conference, we will be talking about a range of findings and approaches and methodologies. So some of the aspects that we have actually worked on so far is understanding the lived experiences of mental ill health and pathways through services. And we have developed applied theatre and community interaction to engage with the communities, to empower the communities as well. Because of the COVID context, we could not actually proceed with that anymore. So we actually engaged with the public engagement through Mental Health Film Festival last year, the MSFF 2020. We also have developed the Mental Health Literacy Questionnaire, which is looking at the cultural awareness, the awareness of mental health and well-being. And we have also developed digital stories and based on cultural narratives. And there are 18 short films based on cultural mental health literacy promotion in Kerala. So with that, we actually move forward in terms of how we promote that and how we actually understand and evaluate mental health literacy in the Keralan context. Thank you very much.
Thank you, Dr. Raghu. I think that was a very good beginning about the program. And I think we'll now go to Dr. Asha, who will talk about mental health care for all in Kerala from Tata Institute of Social Sciences. Over to Dr.
Yes.
Banu. Sorry for that brief interruption. We are fine with that. Over to you now.
Yes. So I will start now.
Yes.
Dr. Raghu has already covered part of it, and I'm going to talk on three dimensions: context, the research context, and the context specific distress, and the mental health interventions in the state. So, if you look at Kerala, it's always called as God's own country with high to very high social development indicators and is ranked at the top among the states and the union territories in India. Proclaimed for the highest literacy rate, highest sex ratio, and also the first state in India to reserve 50% of their seats for women in local and state government, low infant mortality rate, proclaimed for its public health response to Nipah and COVID, and also the doctor patient ratio equal to any of the developed countries, and also affirmative practices for minorities like transgender communities. And also is a state which has diverse forms of performing arts, which brings different groups together and also maintains the collective culture in place. People gather, assemble, do various rituals, and connect through stories through varied performing arts. So there is also this aspect of collective engagement in the community through these performing arts. But at the same time, there are also certain flip sides. While it is called as the God's own country, there are also aspects that calls it as the land of paradox. The state ranks the highest in terms of income equality. On one hand, when we talk about there is so much of the NRI income and the Gulf migration bringing resources, we also see that the state ranks the highest in terms of income inequality because we see the north-south regional disparities and which affects other indicators as well. While we look at women empowerment and Kudumbashri being a phenomenal social innovation replicated across states in the country, we have the highest female unemployment rate in the country. And Kerala also is cited as one of the top 10 states listed as unsafe for women. And also, we see news on mysterious deaths of transgender individuals. So, while on the one side it's faring very well, we also see the flip side where some of the marginalized communities are affected. Taking it further on even certain indicators in HDI, when the state is faring very well in terms of material prosperity, health, and education, within the health domain, again, we can see in certain pockets of the state, there is inadequate access to safe drinking water and the extent of stunting among children, and also highest income security as a result of informalization of labor in many spaces and higher level of unemployment and underemployment in the state. So these are disparities. On one hand, there is this Kerala model of development and good indicators. But on the other hand, there is this flip side where we see lots of disparities, which results in distress in the community context. So some of the disparities and some of the distress I have highlighted here is violence against women. Even when a woman was educated and employed, she still had to perform the role of Grahini, and it was assumed that her primary duty was to raise ideal human and be a support system to her husband by taking care of the domestic chores. So that way, there is enormous amount of role conflicts and role overwhelming, which describes depression amongst women in the state. The next is diminishing informal support networks. Initially, there was a collective culture, but because of some transitions that's going on, there is diminishing informal support mechanisms that has not been replaced by any forms of formal support networks. Recently, also the news covers series of incidents which covers on infanticides where the mothers themselves are killing the infants, and the reasons cited are very many, but then are we also giving it a touch of postpartum depression in the state? The another dimension in which Kerala does poorly is social connection. On one hand, when we are looking at collective culture, diverse forms of ritual arts, performing arts, bringing people together. Now, in the recent one of the survey, Kerala also has poorly scored in terms of social connection, which also may be one of the factors in terms of what explains the increase in the number of suicides and marriage failure rates in the state. Also, we can see male dominated migration, which is like a phenomena over the years to within and outside the country. Feelings of loneliness, hopelessness resulting in depression, suicides among children, women, and men. Higher number of elderly living alone with poor mental health and homelessness, and also influx of migrant population from the north. So these are all certain distress points creating vulnerability to mental health concerns. Now, the mental health concerns and inequalities. um, I just took this a percentage from the state health minister's speech on the World Mental Health Day. That 12.8% population in Kerala have mental health issues, and also it was added only 15% of the total people with mental illness have access to mental health care in the state. The trend in the prevalence of mental health disorders in the state also is increasing over the years, and alcoholism and addiction cited as top post mental health concerns. While I was doing, looking at the current instances and documenting on some of the mental health concerns through the news media, I found that children's suicide as an alarming concern, where post-COVID, 158 child suicides have been reported in the news. And all of this have happened in their own homes. So that's the context. And within the state, the beauty again is the mental health interventions are so robust and there are diverse models. The research, the partners MEHIC and MHAT, they themselves have pioneered in community-based models where they are providing critical care support at the doorstep of the persons with mental illness. The district mental health program several innovations, and in fact the Trivandrum model, which is the first DMHP a model in the state, has been selected as the most successful and model mental health program in India by the World Health Organization. There are also targeted interventions through district mental health programs, school mental health program for the elderly who name a concern. They have the targeted mental health interventions starting from Talir to Tunnel to Mukti to Santavanam. There are several targeted interventions looking at different vulnerable groups. And also, the state has already started years ago the campaign for mental health for all and how to create an inclusive space. There are several other players promoting mental health, like the folk sector, the religious healers, the Ayurveda practitioners, adding to the mainstream mental health interventions. So there is this robust pluralistic systems and lots to learn from the strengths, but also there are gaps between the extent, the nature of the mental health problem and nature of services, resources available vis-a-vis the context. So our project, listening to stories, and us, the conference team spoke about fearless talk. We are engaging in fearless talk with all stakeholders, understanding what's going very well in their lives, understanding the mental health care pathways. And also, the beauty of the project is we are looking at urban, rural, and tribal. We are also looking at equally male, female representatives. We are also looking at caregivers, and we have 8 sites to our study to capture the maximum diverse voices from the state. So these are our stakeholders, the key stakeholders, persons with mental illness. The decision makers most often becomes caregivers, family members, friends, relatives, community in terms of religious organizations, schools, any other spaces, colleges, and organizations that are looking at mental health. And also, when we are looking at through the narratives, these are the systems that interface with the life of the persons with mental illness. One is the religious sector, the second is the community clinics, the third is the Ayurveda sector and the folk medicine, and how all of these players are influencing the healing and recovery of the individuals. So, in essence, this is the mental health ecosystem, and our project has facilitated conversations across these many stakeholders to see how, when we feedback into mental health literacies, will inform and transform the systems in this ecosystem, the micro as well as the meso and the macro systems within this larger ecosystem of mental health. So, what do we do to make it a possibility? That's the mental health for all. It's very important to explore and address disparities. There are universal models. We are picking from universal models. There are protocols. But again, how are we going to create using that universal model, some inclusive context-specific models to address the vulnerabilities within the state, and how we evolve context-specific mental health literacies, which will feed back into the ecosystem that's governing the lives of persons with mental illness. So the strength of the state is intersectoral collaboration, the pluralistic way of looking at it, and how to tap from these strengths and create a robust mechanism and work towards the quality of life of all the persons with mental illness with rights envisaged in the community. I think with this I conclude. Thank you so much.
Thank you, Professor Asha. I think it was very, very detailed and very enlightening description about how Kerala has come this far. And it was music to my ears, meaning, as someone who wanted to take up psychiatry 40 years back, finding no MD seat in Kerala and had to go out and then come back. We are delighted to inform you that we have more than 40 MDs coming out every year, and many of them are women and wanting to stay back and work in Kerala. So I think good times are ahead. What we need is collaboration and networking. I look forward to it, and I think we now will move on to listen to Dr. Nadia Svirydzenka, who is again from Montfort University in the UK. She will talk on interdisciplinary methodology for MeHeLP India project. That be very, very useful. Over to you, Nadia, please.
Thank you. Right. So you should be able to see that now. Hopefully you can hear me okay. Excellent.
Slideshow.
Perfect. Okay. Thank you, everybody. Thank you for joining us. I will complement the comments made by Asha and Raghu. They've set out the context so well for Kerala and for this project specifically, and why we came in to do it specifically in that state. My presentation is about the how. So we understand the need, we know why we wanted to do the project, how did we actually do it, and how did we do it interdisciplinary, and how did we amplify those voices and carry on that ethos through the project. So what we've done in the overall methodology of the project is employed an emancipatory research paradigm. We wanted to do participatory core research methodology in this project. We wanted to connect with the local communities in Kerala and understand their lived experiences in order to understand their mental health literacy. For that, we've used theatre and storytelling methodologies, both to engage and collect the data. A lot of times, some of the creative approaches is not seen as a research method. They're seen as a part of art, something that you enjoy, something that tells a story. We have used them to have conversations with immediately affected persons in our project. We wanted to connect to service users, to their families and carers, and to community members to understand the lived experiences of individuals who have had mental illness and have accessed different services, and how they understand their mental health, how their families critically who care for them understand mental health, because the care and availability of resources and the coping strategies are very much shared within the family. And also community who form this backdrop, and they form the space where these values and norms and understandings about mental health are shared and they're transmitted to younger generations. Importantly, the views of these groups are seldomly thought in general research, and their voices are very rarely heard. So we wanted to amplify their experiences in our project. And the aim for that was to reconstruct their knowledge and their ability in the process of understanding and empowerment. So this was a transformative project, both for the communities, but also for us. So it's not just about research finding, but it's about what the research process was doing. So as I said, we've employed a participatory approach. So as Anu and Plato say, that participation in research is a process in which ownership of the problem is increasingly shared between researchers and the researched. In the first instance, the researchers likely to own the problem and design the research using methods that enable stakeholders to express themselves, working directly with stakeholders and gradually handing over responsibility to them to set the research agenda will change the role of researchers to facilitators and turn the research process into a joint project. And it's, I like this quote very much because it speaks to the ethics of how we've conducted this research, why we've employed creative methods to do this, and tomorrow you'll hear more about that. And particularly wanting to transform mental health literacy, not just something that we'll learn about, but something that we share and something that we can take on, and develop that agency around the communities and the clinicians and families and the users to take ownership of their mental health and mental health literacy and have those conversations. So what we've done is a multi-center study. We focused on 4 Kerala districts, Palakkad, Kozhikode, Malappuram, and Ernakulam, which constitute close to 40% of the Kerala population. In each of those districts, we have selected a rural and an urban site. So because we've started this project to understand different contexts of Kerala, we didn't want to homogenize everybody and say everybody's the same and everybody has similar experiences. We wanted to understand local cultural variations in Kerala and how different contexts, such as, for example, villages with farming communities, your tribal colonies with low income levels and living standards, compared with towns and cities with higher income and living standards. Because obviously the contextual variables that will vary between those contexts will very much influence the experiences of mental health, how people access support services, how they understand treatment options or recovery for mental health, for example. So speaking to the kind of the diversity of mental health literacy construct that Raghu has talked about. So this was quite a complex project because we used mixed methods. So we used qualitative and quantitative methods to understand mental health literacy. But also we put a lot of effort in engaging with creative methodologies and not have them run in parallel and not interacting with each other. We very much wanted to have intersections between the traditional, so to speak, research methods, your interviews, your surveys, and also creative approaches. We wanted to have true disciplinarity in the team and in the project. So what we've done, we've started with storytelling, right? I've said before, we wanted to understand the lived experiences. So we've collected narrative interviews in 4 regions of Kerala, as I said, with users, carers, and community members. So this was our primary point of data collection, and I'll give you numbers for these a bit later, just to give you an overview of how amazing and massive this project is. So we've done storytelling, and our researchers went out to communities. They've built relationships with those communities, and they've spoken to our target groups. From that, we've also engaged with the theatre makers on the project to produce clinic plays. So play scripts were developed from some of the key themes that emerged from the narratives, and that were adapted to the different cultural contexts that we have within the locations of the project. This was done both to engage the communities further in the communication around mental health literacy, and also co-create new knowledge, to have them reflect on the narratives that were depersonalized to some extent, so they're sensitive and anonymous, but at the same time something that they could connect to, that made sense and were commonplace in their community. From there, so from using the storytelling, from using the discussions and insights from the clinic plays, we went through a process of cultural adaptation of a mental health literacy questionnaire for equivalence, for cultural equivalence within the Kerala context. So we've done quite a bit in that. We've done measure adaptation and development process that was quite in depth. And I'll speak more about it in the workshop, not to do a pitch here, but again, to kind of understand the construct of mental health literacy. And that at that point is when COVID started. So you can see it kind of hit us in the middle of the project when we were doing a lot of data collection. but we were keen still to engage with the communities, to engage with people about their mental health literacy. So we have initiated a film festival, both in educational kind of engagement, but objectives, but also in terms of promotion of mental health literacy, to communicate with people using film around mental health. As well as the film, after that was a massive success, we have used the narratives and the clinic plays to develop digital storytelling, again, as a process of co-creation with individuals that told their stories, but also for engagement and promotion of mental health literacy across different contexts, both educational, clinical, health contexts, but also within the communities. From there, we have also developed film scripts used from different directors. And again, they're being screened here at the conference, and you can engage with them. And they can be promoting mental health literacy in constructs that we have just uncovered in Kerala. And adaptation of mental health literacy is still continuing. So we're still collecting data, and we'll be promoting some of the links on this conference. So please do engage with that. And it'll be great to have your insight into that development as well. So just to highlight how massive this project is and how amazing our team has done in terms of data collection. So first of all, we've collected the narratives, as I said. We've collected altogether 192 interviews across service users, carers, and community members, which is amazing. It's, again, across all of the 4 districts in Kerala. Produced 8 clinic plays. That scripts were adapted to local narratives. They had variation, they had local relevance for engagement, and kind of shared community identity around those narratives. Produced 6 digital stories from the narratives that we have collected. We had a film festival that was a massive success with 500 submissions. 77 were evaluated with a panel, and 20 of them were shortlisted. Again, they're showcased on here and our YouTube channel. We produced 18 films, and when we were adapting the mental health literacy questionnaire, we have piloted the questionnaire with over 300 people in Kerala. The researchers have conducted 40 cognitive interviews to understand the local meaning of certain vernacular, certain terms, to understand how certain items in the questionnaire landed with different populations. And also, we're still doing the second pilot, trying to link it with related constructs. So again, this is ongoing, and we have close to, over 150 people now in that project. So we've done really well, and hopefully this gives you an impression of how we've executed this project, and that you will learn more about as the conference goes on. So thank you very much for your attention.
Thank you, Nadia. I think that was very useful to learn about the complex but then very elegant mixed methodology paradigm which you have used. And I'm sure when this gets published, we'll be richer information-wise. I think this is very innovative too. I think we will now quickly move on to Amanda Wilson, who is a qualitative psychologist. We discussed, I introduced. She will be now dealing with mental health user. There are 3 people presenting there: mental health user, family carer, neighborhood perspectives from urban, rural, and tribal communities. That's a very interesting presentation panel. Over to you, Amanda, now, if you can.
Yeah, thank you. Hello, everyone. Good afternoon and good evening. So as said, we're going to be talking about the thematic analysis of interviews with mental health service users, family carers, and neighborhood perspectives of mental health literacy from urban, rural, and tribal communities. So there's a bit of overlap with Nadia's slides, so I won't repeat the information. But in each district, we had 1 rural site for data collection, 8 primary research sites. These sites consisted of villages with farming communities, tribal colonies with low income levels and living standards, and towns and villages with higher income and living standards. So just to place it within the context of the larger project, we were aiming to answer our overarching research question, which was how effectively can we promote culturally appropriate mental health literacy in urban and rural communities using applied theater methodology. There then were specific research questions that can be answered using the qualitative data. So how is mental health literacy shaped by economic, social, and cultural contexts? How do urban and rural communities construct a culturally and socially appropriate meaning for mental health literacy? How can we best engage with urban and rural communities in Kerala to discuss poor mental health? And we had one objective that was particularly applicable, which was that we developed narrative data sets on experiences of, like we said, service users, carers, and community members. So the most of the interviews were conducted in Malayalam and translated to English. A few of them were conducted in English and a few of them were conducted in Tamil. We're using a combination of open-ended and structured questions to get knowledge, awareness, causes, effectiveness, and acceptability of support. We also explored experiences of journey through mental health services, attitudes of families, friends, employers, and their immediate community, social network contacts, and their attitudes towards people with poor mental health. So to break down those 192 interviews that were conducted across 4 districts, we had for urban 24 service users, 24 caregivers, and 24 community members. For rural, we had 17 service users, 17 caregivers, and 17 community members. And in the tribal community, we had 8 service users, 8 caregivers, and 8 community members. So the majority of interviews were with females. So we had 121 compared to males, which we had 69. However, I'm not surprised to see that there's a skew towards female based on the migration that occurs for work within the area. Looking at the religious breakdown, because we know that religion does feed into culture, we had 122 Hindus, 54 Muslims, and 11 Christians participate. I'm now going to pass over to Dr. Sanjana, who will talk a bit more about themes.
Yes.
Unmute, Sanjana.
Can you see the slides?
Yes.
Yes, thank you. Sorry about that. The knowledge of risk factors and causes are influenced by the socio-cultural milieu, and the interviewees attributed illness to more biological and psychosocial causes in the sites of Edapally and Calicut, while in Ponnani, erroneous and cultural beliefs of causation are common. Tension or stress was a common theme across subgroups, and what was specific to the urban side was the societal pressure, work issues, and the family atmosphere. Now, when it came to healthcare support, interviewees talked about their experience with psychiatric management. They feel that medication, along with therapy, helps them to go about their daily lives. Traditional healing methods like Ayurveda were also mentioned. Ponnani was quite an outlier when we looked at the urban sites, because here you see a lot of alternate management methods being mentioned. Now, social cultural strategies, of course, form a very important part of well-being in the urban area, and people talked about engaging in recreation activities like reading, watching movies, physical exercise, and there was a mention of self-help books and videos, which were very important for well-being. Several participants also spoke about how astrology and predictions made a big role in decision-making in their households. Now, coming on to when you're talking about the attitudes with respect to the family, now, families in urban communities were a source of support and stigma. And what we found amongst the service user was the theme of autonomy and the importance of being in control of things. And the interviewees felt that, kind of described a debilitating feeling of a loss of control, and there was helplessness and hopelessness attached. And they also spoke about across the sites, Calicut, Edapalli and Punani spoke about this inability to carry out tasks and household chores. And in these sites, the emotional burden was stressed upon more with respect to the caregiver. When it comes to gender norms, women across the service users and caregivers and community members spoke of the oppressive gender norms. Girls are supposed to behave in a prescribed manner and get married at the right time. And when it came to the community, an overarching theme is a lack of support and empathy from society. So service users feel ostracized in their community and are mocked by peers and neighbors. The common stereotypes that we often heard in the narrative interviews would be, mental illness is incurable, and that people with mental illness cannot get married, so on and so forth. Now, when it came to knowledge around mental health, the first line of support was often the friends and family. And change, according to the larger community, can be brought about by government policy reform and affordable care. A focus on better mental health care for children and older populations could be by spearheading reform in school administration, curriculum, and geriatric care, according to a lot of community members. Now let's move on to the rural community or the rural sites there. So here we looked at 4 sites. We looked at Erapalli, which is at the border of Tamil Nadu and Kerala. So we had a bit of influences from the other state. Vailattur, which is a district in Malappuram. Chotannikara is often called a temple town, and Payoli in Calicut. So people living in rural Kerala primarily associate the causation of mental health problems primarily to God's destiny and supernatural causation. They often said that mental illness is caused by ghosts, or there's jinn possession, or some supernatural entity. In rural Kerala, a lot of the interviews stress on the financial burden. The need to buy food, the lack of money to buy food supplies, medicines, and basic amenities. They share the aspirations of owning a home and a more stable future. Now, what was evident from the health support was the psychiatric pluralism. It was evident in narratives across the rural communities in the state. And in our study, we found that the choice of mental health care was based on awareness, accessibility, and affordability of resources. Family of service users often resorted to multiple avenues of mental health care. Even though rural participants did endorse the traditional methods, they did believe that taking psychiatric medication along with religious observance will help them recover. Faith healers emerged as the first line of management, and we found that Ayurvedic management is mentioned in many of the accounts. Now, it's interesting to note when you look at rural families in Kerala, what we found was that the need for autonomy isn't that important a theme in any of these 4 sites. There was this fatalistic acceptance of mental illness and a general air of uncertainty and fear of future amongst the caregivers. In Ailapalli especially, we found accounts of intimate partner violence and alcohol abuse. Family was an important source and is an important source of support, and the responses were mixed with incidents of conflict and violence towards the carer. Service users speak about issues they face at home. There is disinheritance, there's abuse and estrangement. And on the other hand, there were accounts of strong familial ties and bond. And this showed that family support is also integral to recovery. In the communities, just as we saw in the urban areas, social isolation and stigma are dominant themes. And they affect everything from work prospects to marriage and education. Now, where do people in the rural areas get their knowledge about mental health from? It's a more collectivist society, you could say, in the rural communities. Families and neighbors were viewed as more likely to be a source of information. Religious support was also there, and for a lot of our participants, the clinicians and the health workers of the NGO provided mental health education. So that was a brief overview of the urban and rural communities. To take you through the tribal communities, we have Aarcha.
Over to you, Aarcha.
Thank you. Can you hear me?
Yes.
Okay. Now let's travel to the tribal areas of Attapadi. So these are actually reserved forest area and one of the least developed areas in Kerala with very poor literacy level. And majority of the population in Attapadi are tribal. Next slide. Okay. Now moving to their explanations of mental illness. As in any other side, they have biological, psychological, and social explanations to mental illness. And the interesting social and cultural element is what I would like to share with you. One of the major social elements they associate mental illness is through alcoholism. So they believe that chronic alcohol use, which is which is a major social issue in Attapadi, is one of the major reasons of mental illness. And having on the other side, having a family member with chronic alcohol use is again a burden for the women and children of their families, which is a cause of mental illness for them. And the cultural and the other social elements are when they have to make a change, shift from the place of origin to town for educational and for employment. They face ragging, they face bullying, they turn up to end in bad friendships, which are again considered as cause of mental illness. Now, the cultural explanation says that various elements in the nature, like the wind, air, and water, have something to do with mental as well as their physical health. So, and again, black magic and possession is also considered. Then they believe that one has mental illness because he or she is born in a place which is cursed. That is another expression which they give for as a causal factor. Now, coming to the healing of mental illness, originally all of the community members in Attapadi go directly to the cultural or religious practices of healing, like the herbs, Ayurveda, black magic, and religious practices. But then there is a gradual shift to the modern medicine when we closely look at the narrative. So this shift is what it is an interesting finding in our study. Now, the major challenges they believe to their mental health is lack of nutrition, as due to various governmental or various policy changes, they are not allowed to go to deep forest and get their food. So they believe that they don't get good nutrition now. Then again, substance abuse, educational backwardness, and lack of support systems. And another very major challenge they face is the stigma. They feel that the service users are not accepted by the society, and often they are laughed at and made fun of. They themselves have the elements of internalized stigma where they try to hide their conditions from others, especially in situations of marriage. When they're trying to get an alliance, they hide the condition, fearing to lose the marriage. And they also have various guilt and negative judgments about themselves, the service user. So these are the few internalized stigma elements which we found. And what the community members want from us, from the health service workers, are awareness programs and education in terms of mental health literacy and health literacy. They asked us to give awareness to their children so that at least the next generation would be aware of the negative sides of substance abuse, and they are aware of the mental health condition. Thank you.
I think, thank you very much, Archa and Aman. So I think we have, as the timer says, we have 2 more minutes, but I think Indian Standard Time wise, we have another 2 minutes. So I don't know which one will you go by. I think chat box, generally state chat box, nothing much question wise. I think one thing which all of you should know is that we had done a large epidemiological study few years back, published in 2017, where we surveyed 5 districts and Palakkad was one. We have published part of the data and we have the data. I was the principal coordinator for the state. So there is a wealth of data on which a population representative sample of people above the age of 18 were screened for common mental disorders and various other uh, easy to diagnose conditions using community-based screening tests. So we have that data. We'll be happy to share with you that data and work on that data, because this was done in I think 2014 to 15. So we have it's a population representative data for the district, and Palakkad was where I was also the I was coordinating the district. I was coordinating 5 districts as the PI for the state, as well as I was supervising Palakkad personally. So it's a very good data which I have. So it will be very interesting to look at those data with this information. And treatment gap obviously seems to be quite large. I would want from organizers to tell us whether we have finished our time or we have 2 more minutes. If 2 more minutes are there, all of you could take a quick last comment. All speakers starting from Asha, then to Raghu, and then in that order. Is that okay? Another 2 minutes, do we have someone to tell us, or we have just finished our time? Raghu?
Yes, we got a green light for 2 minutes.
Yeah, I think we are it. That's it. We have the time is over, I think. So I'm sure we can continue with the conversations and the questions throughout the conference. And so feel free to actually chat with us and raise the questions with us. Sorry that we some teething problems, and I think some of the initial stuff.
That should be right. I think I want all of you to understand that Kerala University of Health Sciences, you heard from the Vice-Chancellor that we'll be happy to help and be in touch and collaborate. With 40 years into psychiatry, I am heading the research section and in charge of the PhD program downwards. So let us do many things together. That's the key. Thank you for the opportunity, Raghu, and all of you.
Thank you.
Thank you, sir.
Thank you. Thank you.